Okay, so
Yeah.
greetings and a warm welcome to everyone. This is Rupsha, the assigned moderator from Clirnet. It is my sincere pleasure to extend a heartfelt welcome to all the delegates joining us across the country. We are indeed fortunate to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us on today. Now, allow me a moment to introduce our platform Clirnet. It stands as one of the largest live digital semi platform in India, providing a space for doctors to create and share their medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Amitabh Banerjee, sir. Sir has completed MBBS and MD. He has also done postdoctoral in epidemiology, professor and editor in chief medical journal and head of community medicine at Dr. D.Y. Patil Medical College, Pune. Now, I would like to take this opportunity to provide a brief overview of today's topic, which is dysentery. So, dysentery is characterized by diarrhea with presence of blood and mucus in the stool. It can be life threatening due to the risk of severe dehydration. Various infectious agents, including viruses, bacteria, protozoa, and parasite worms, can cause dysentery. It may be it may also be triggered by chemical irritation in the intestines. Effective treatment involves rehydration, antibiotics or antiparasites, and improved sanitization. Preventive measures include ensuring access to clean water, proper sanitation, and hygiene practices to control the spread of the disease. So, without any further delay, sir, I would like to hand over this topic to you. Please proceed with your talk, sir. Over to you.
Thank you, Rupsa. And it's always a pleasure to come on ClearNet platform, and greetings to all my colleagues all over the world from Pune, India. So today we'll be talking about dysentery, its epidemiology, management and treatment and prevention. Being a very important infection, particularly in African, Latin American, Asian countries. It's a major tropical condition, and it has got lot of common. It is lot of common features with diarrhea, but it is more severe when there is blood in stools, particularly involvement of the large intestine. It can become very serious and dehydration and requires urgent management and treatment. So I'll be giving the main overview of this would be the scope of our discussion today. What are the causative agents? Broadly, they are bacterial and protozoal. Sometimes it may be due to other agents like in tropical countries, worm infestation, particularly Trichura trichuris. So, what are the causative agents? Epidemiology, it follows that of diarrhea, where the hygiene and sanitation is poor. Then there have been cyclical patterns of disease has been noted. Every 3 4 years, there are spikes in diarrheal diseases and dysentery. Incidence, clinical features, lab diagnosis, treatment. And this is a bacillary dysentery and amoebic dysentery. These are the two major. The second is amoebic dysentery, where the history of travel is important, history of pain abdomen, type of stools, then causative agent, life cycle, epidemiology, clinical features, lag and amoebic dysentery. And the, just to give a brief history of dysentery was present in ancient times from the time of Hippocrates, and he defined it as passage of stool containing blood and painful defecation. It was only at the 19th century when cause of amoebiasis and bacillary dysentery were determined, and the two great forms of dysentery could be accurately separated. In 1859, in Prague, Lambel and then Osler, the famous clinician and councilman, and Lafleur helped verify the pathogenicity of Entamoeba histolytica, protozoa, amoeba, which is a major cause of bacillary dysentery, amoebic dysentery. In 1906, Siga is the scientist, demonstrated bacteria in stool of many patients with dysentery, and agglutinants could be demonstrated in the serum of infected patients. And that is how the name Shigella and Shigellosis had come after this scientist. So, as I said, dysentery broadly can be classified as bacillary and amoebic. These are the very broad classifications. Subsequently, of course, there are other causes like worm infestation, trichuris, and or chemical or other things. But these are the two major forms, and we will be discussing first bacillary dysentery. So, the most important pathogens for bacillary dysentery are Shigella and enterohemorrhagic E. coli 0157 strain. So Shigella organisms are small gram-negative rods and they belong to the family of Enterobacteria type 1 Escherichia, genus Shigella, non-motile, non-encapsulated. So they are gram-negative agents, Shigella, and Shigella dysentery has the potential of triggering outbreaks and rarely pandemics as well. So these are very important to identify early because of its outbreak potential, Shigella. Then types of Shigella are four groups depending on serology, similarity, and fermentation. This is more important for the microbiologist. For clinician, treatment is same. Group A, Shigella dysentery, then Shigella flexionary, Shigella boydii, Shigella soni. So these are for the microbiologist. Epidemiology of Shigella Hippocrates was the first indicated that when dry winter was followed by rains, an increase in number of dysentery cases would follow in the summer. This is his observations, and we know that when there are heavy rains, there is flooding, there can be cross contamination of uh, fecal and water supplies. The transmission is fecal-oral route, and particularly presently in India, we are having heavy rains all over, so we have to be on alert for dysentery or diarrhea also. Seen in children living in crowded areas with inadequate sanitation and limited water. Most of the poor people in countries of Asia, Africa, they stay in slums, and with this flooding and all, they can be and poor sewage lines, they can be a hazard of contamination of drinking water and diarrhea and dysentery. So this is the particular appropriate time to discuss this. People are alert. Because of the clinical picture of bacillary dysentery, it is one of the most accurately diagnosed and reported cases of infectious diarrhea. Because blood is there very frequent, there is pain in the abdomen, the stools are not as foul smelling as in amoebic dysentery. Tenesmus is there, pain abdomen. Then the flies can also transmit, but mostly it is fecal-oral and person-to-person transmission through food, water, and personal hygiene, poor personal hygiene. Cyclical pattern had been noted in earlier times of bacillary lasting 20 to 50 years. In Europe, during the 25 years of 20th century, disease generally caused by Shigella dysentery between 1920s and 1938. Then this is earlier times in the Western countries when sanitation was not as good, which we are facing now. X-flexionary strains became more prevalent than the Shiga bacilli in the developing world. Shigella soni has become the major cause of bacillary dysentery in European countries and the United States. So there are certain geographical distribution of the different types, serotypes of Shigella. Shigella soni is more common in the USA and European countries. This can be helpful in tracing the source of infection. Shiga dysentery remains a specific problem in parts of Africa, the Indian subcontinent, and Bangladesh, where epidemic strains showing greater resistance to phagocytosis cause pandemic disease. So, as I said, Shigella has a potential for triggering outbreaks and pandemics, and particularly in the Bangladesh, Indian subcontinent, Africa, where the strains are more pathogenic. Incidence, the annual number of Shigella episodes worldwide had decreased from 165 million cases and 6 lakh deaths in 1990s to an estimated to 27,000 deaths in 2016. So there has been a great improvement in this, perhaps related to hygiene sanitation, and people have become very conscious about taking safe drinking water. Most people take filtered water or bottled water. However, that what ideal conditions should be, the tap water should be fit for drinking by proper insulation from sewage contamination, and proper filtration and chlorination with residual chlorine. So that is the should be the goal of public health. Taking bottled water or filtering water is a failure of public health. It is protection at an individual level with the cost involved. So anyway, whatever the reasons, so in the past 3 decades, there has been a marked decrease in the incidence of Shigella dysentery. The highest rate of Shigella infection, 69% of cases, and the highest death rate, 61% of deaths, are in the younger children, under 5 mortality. So it's a major cause of under 5 mortality in Asian and African countries. And not only that, it can cause malnutrition, underweight. So there is a vicious cycle. An underweight child is more susceptible to intestinal infections like Shigella and other infections. And other infections causes loss of fluids, poor absorption, poor nutrition, and leads to malnutrition. So malnutrition infection cycle, once it sets in, the child, it increases the child morbidity and mortality, particularly under 5 child morbidity and mortality. From 2006 to 2015, between 1190 and 2308 culture confirmed cases were reported annually in the United Kingdom. So you see, United Kingdom also is not, there are maybe some pockets of Shigella, but not as much as in developing countries. In the United States, about 2000 plus cases were reported to CDC in 2017. So because there are a lot of migration, later immigrants, lot of people in staying in with compromised hygiene sanitation, even in the developed countries. So there may be pockets, marginal pockets where such conditions can be reported in the developed countries also. So these are the pathogenesis, this whether it is Shigella or other E. coli strains, invasive E. coli strains, Shigella and Entrop or invasive E. coli. It invades the colonic and rectal cell. As I said, dysentery is due to the inflammation of the large intestine, colon, and the rectal cells, including M cells of the follicles, associated epithelium, macrophages, and epithelial cells. Invasion is followed by intracellular multiplication, spread of infection to adjacent cells. Bacteria multiplies. Severe inflammation and destruction of mucosa. Apoptic destruction of macrophages in subepithelial tissue. Inflammation facilitates further bacterial entry. It's invasive. Organisms multiply within the cytoplasm and move from cell to cell by actin-dependent process. So it's a quite an invasive path. And mode of transmission is a fecal-oral, person-to-person transmission, waterborne, foodborne, and secondary transmission, person to person. So it is the prevention also depends on the modes of transmission. Clinical features: bacillary dysentery cause fever, loose stools with mucosa blood, abdominal cramps and tenderness, pain, hyperactive bowel sounds. Infants may show hyperpyrexia and seizures. Hemolytic uremic syndrome is a special complication of enterohemorrhagic E. coli, strain 0157. And if most of you who may be reading fiction by Robin Cook, the book Toxin by Robin Cook is a fiction around hemolytic uremic syndrome caused by enteropathogenic E. coli, strain 0157. Mostly it is transmitted by poor hygiene of meat products. And in this novel, it is shown a hamburger which is contaminated in the food industry. The supply chain gets contaminated. And so these are the hazards of poor production, poor hygiene sanitation during production of edible foods, particularly meat products. So diagnosis, lab diagnosis is gold standard is stool culture. Direct fluorescent antibody microscopy may be used in detecting the organism present in small numbers. NAAT, this is, I think, nucleic acid amplification test. Nucleic acid amplification test target a gene both Shigella and entro-invasive E. coli, and therefore the report does not distinguish between the two organisms. So it's difficult to distinguish, but yeah, can epidemiology you can distinguish Shigella and E. coli, but the gold standard still remain the stool culture. NATs do not provide information on species of drug susceptibility. Shigella or enteropathogenic E. coli, enteroinvasive E. coli identified with NAT should be conferred by culture for species, serotyping, drug susceptibility testing, and for epidemiological purposes. So ultimately, for full investigation of an outbreak, you require the culture. For clinical management, you can send a culture and start the antibiotics because it can be life-threatening. Because the frequency of stools can go up to 100 a day with blood and every 15 minutes, and you require urgent rehydration, IV fluids, and you may have to start antibiotics before getting the result. The single most important laboratory test is direct microscopic examination of a stained fecal smear, which will show numerous polymorph leukocytes. So this is the picture. Fecal smear. Then serological evaluation of a patient with bacillary dysentery is not generally helpful in establishing diagnosis because humoral antibodies do not develop before recovery. So it takes time to, there's a long window period. So for diagnosis of acute case and management, the serological evaluation is not very helpful. It is only as an epidemiological tool subsequently to know the extent of the endemicity. So serological evaluation may be helpful in epidemiology, but not in clinical management. So these are the drugs, common antibiotics, ciprofloxacin and all. They are the drug of choice, and other ceftriaxone, cefixime, levofloxacin, and azithromycin. So depending on the local sensitivity reports, so these are the drugs, and it has to be started early after sending for culture. So whatever the antibiotic spectrum, and this is basically for bacillary dysentery with Shigella, and of course enterohemorrhagic E. coli, which requires supportive treatment, and there may be hemolytic uremic syndrome is a particular complication of enteroinvasive E. coli 0157. There is hemolytic anemia and renal failure, uremic syndrome, which has got a very guarded prognosis. And these are the two major bacillary causes of dysentery. Besides that, there is also salmonellosis. That's also a bacilli that can also clot blood in stools. So salmonellosis is by the rodents. They are the reservoirs, small rodents which may contaminate the food, and it may cause blood. And antibiotic is not very helpful in salmonellosis, but it may prolong the carrier stage. But then there may be other causes of bacillary dysentery like Campylobacter jejuni. Then there are other antibiotic associated also. I have got a book on tropical medicine. They have given large number. Oxford textbook of tropical medicine. So I just considered all the main things. So acute diarrhea with blood, Campylobacteria enterocolitis like Campylobacter jejuni. So Salmonella, then there can be other. Uh, these are, I just wanted to finish. Clostridium difficile associated with diarrhea and colitis. So that is a side effect of antibiotic use, in particular in elderly people. Clostridium difficile. Antibiotic associated colitis. So this just give an overview of the bacterial causes. Now we move on to the amoebic dysentery, which is important in, of course, earlier it used to be more common, but as we saw, just like with Shigella, with improved hygiene sanitation, even in developing countries, the incidence has come down, but still there are cases. So amoebic dysentery is also a major, and historically Hippocrates had mentioned about this dysentery if it commences with black bile. Black bile means mortal, and the Old Testament classic of internal medicine also made reference to dysentery because it has extra amoebiasis, extra hepatic. It can cause hepatic amoebiasis and black bile. In 1828, James Amnesley may have been the first association of dysentery to liver abscess. So amoebic liver abscess is an important complication of amoebic dysentery. When he wrote in Prevalent Disease of India that hepatic disease seems to be induced by the disorder of the bowels, more particularly when this disorder is of a subacute or chronic kind. The first North American case of amoeba was reported by the great clinician in 1890, Sir William Osler. Amoebiasis has got a myriad sign symptoms. It can go to extra intestinal sites, like particularly the liver is most common, then can go to the lungs, can go to other organs also. It can cause some sort of swellings in the intestine, mimicking tumors, amoebimas. So causative agents is Entamoeba histolytica. Entamoeba species are subphylum Sarcorea class. So it's a protozoa. Basically, it's a protozoa, not going into the details. So many infect humans, but Entamoeba histolytica is the one which causes the maximum symptom. Other Entamoeba may be there, particularly Entamoeba dispar. I have not mentioned it here. So, which may be mimic, which is very difficult to distinguish it from histolytica, and therefore there may be an impression that some cases of infection with amoebiasis are asymptomatic. So, subsequently, the thinking is that it is the other strains which are cause asymptomatic infections, not Entamoeba histolytica. But it is microscopically difficult to distinguish between Entamoeba histolytica and Entamoeba dispar, which can cause asymptomatic infection. Only E. histolytica is a cause of invasive amoebiasis, whereas E. moscovici is associated with non-invasive diarrhea and other two are non-pathogenic. I said there are some non-pathogenic also. I mentioned dispar, but here they have mentioned others also. So we have to remember that Entamoeba histolytica is the one which causes invasive disease. So life cycle is again the fecal-oral route, and the acute symptomatic phase, lot of trophozoites. It has got two forms, the trophozoites and the cyst. The cysts are the carriers. Those who pass the cyst are the carriers. Those who are suffering from acute dysentery, they pass the trophozoites, and trophozoites are not very viable outside the human body, so they are not very infective. But the cyst, where the patient is not suffering much, but maybe passing the cyst, which is infective, which once ingested, it can then go into the cycle of trophozoites, which can be invasive, causing amoebic dysentery. So the trophozoites are the one which multiply and cause the pathology. So, and it is shown here that the liver may be affected from the intestine. The trophozoites may go to the liver. It can cause liver abscess, and it can digest the liver tissue and liver cells and cause a sort of a brownish fluid, which is the digested liver cells, which is sometimes ruptures into the lungs, and the sputum traditionally is known classically the anchovy sauce. Anchovy sauce is a brownish fluid. Anchovy is a sauce. Anchovy is a fish, and anchovy sauce may be made from this fish. So it resembles anchovy sauce, which is a digested liver cells due to, I mean, destroyed liver cells by the trophozoite. Sometimes it goes to the lungs. It can goes to the brain abscess. It can cause. So once it can goes beyond the intestine to liver, to the circulation, liver, lungs, then other parts of the body, it can go, particularly the brain. These three organs are important. So treatment is very important, and early diagnosis and high index of suspicion from people who are coming from areas of poor sanitation, poor water supply, poor sewage. So high index of suspicion has to be there because the treatment is very effective. Particularly, there are two targets. One is the intestine and one is the extra-intestinal. So the epidemiology of amoebiasis is incidence from 35 to 50 million cases worldwide each year, and many years, almost 1 lakh deaths. It is quite a appreciable morbidity and mortality. The bulk of morbidity and mortality in Central and South America, Africa, and Indian subcontinent. A carefully conducted national serological survey in Mexico demonstrated at antibody to E. histolytica in 8% of the population. Urban slums of Brazil, 25% tested carrying antibody. So you see, the slum it may be more. Dhaka, Bangladesh, diarrheal disease leading cause childhood death. The infection in cohorts of infants and preschool child were greater than 40%. So there are pockets in slums in highly dense countries where